MD, PharmD. Terell D. Corning, Senior MD, PharmD, is a practicing physician fellow at Durham, North Carolina. Dr. Corning began his healthcare professional journey as a clinical pharmacist at a cancer center in Tallahassee, Florida. After practicing pharmacy for a few years, he decided to embrace his curiosities and pursue medicine. Dr. Corning is an aspiring multiple myeloma specialist who is training at Duke as an oncology fellow. More than Dr. Corning's role as a physician, he is also an effective community leader with extensive experience of mentoring. When pursuing medicine, he lacked mentors, simply because he lacked access to physicians in his community. So he understands deeply the challenges of considering a career in medicine when coming from a disadvantaged background. He is a believer of lifting as he climbs, and that is why he served as an executive board member of MediHughes, Inc., a nonprofit mentorship organization that he helped establish. His overarching aspirations are to help students successfully pursue a career in medicine. With his past organization, he gained experience with mentorship, test preparation, CV, resume writing, and interview preparation. He also helps students gain shadowing opportunities for those with limited access to these experiences. This work is extremely important and meaningful to Dr. Corning because he strongly feels that people's dreams and aspirations should not be deferred due to their inherited circumstances and environments. In addition, Dr. Corning is a patient educator and is passionate about educating the community regarding common but vital health topics. In that spirit, he had a podcast, Real Health Talk with Dr. Corning, that focuses on improving health literacy in our community. Overall, Dr. Corning is looking forward to helping you achieve your best success. You will appreciate his humility and excellent work ethic. He has an extensive work history with plenty of leadership experience. It is his hope that he can build a dynamic relationship with you, grow with you as you begin to embark upon your multiple myeloma journey. All said, Dr. Corning embraces the opportunity to start a working relationship with you with hopes to guide you to learning and embracing multiple myeloma and other hematological malignancies. I said it, right? So at this time, we're going to present our speaker, Dr. Terell D. Corning, Senior MD, PharmD. Please give a hand. Okay, I appreciate that.
And thank you to Tony and the sponsors, and thank you for you guys for wanting to come here and be educated and learn more about how to take care of yourself and also your family members. Facilities such as Duke, UNC, Wake Forest, places that are urban. And so if you don't have access to these urban centers and you live in a more rural, remote area, access could be a problem. But there are organizations like Blood Cancer United, which formerly known as LLS, could actually give you access to these places. They have transportation available, they have resources, vouchers for you as well. And so there are ways to access clinical trials. But I'm an advocate for clinical trials. Just know that clinical trials is not the all be all, but it can be beneficial, especially if you're a later disease like stage 4, for example. And so clinical trials is a treatment option. But the fact of the matter is, one of the primary reasons why we aren't doing as well as we should as far as cancer treatment is because we don't gain the access that we need to get to these treatments. And when we don't have access to these treatments, we don't do well. And then the second thing is we're not diagnosing cancer at its earliest stage. We don't do well with the screenings. And so it brings me to my next point. We should be screening for breast cancer on average at age of 40 with mammograms. You have a strong first signs that get dismissed for multiple myeloma is back pain. And there's not a designated screening for multiple myeloma, but there are preliminary labs that we do order for that diagnosis. All right, so then we talk about treatment. How do we treat blood cancers? We have a plethora of things we can do to treat blood cancers, but the primary treatment for blood cancers is chemotherapy. We also use immunotherapy, which is something called CAR T cell therapy. It's a fancy way of saying we take your own immune system, and we tell your immune system to find these cancer cells and attack these cancer cells. That's called novel therapy. This therapy is only really accessed at institutions like Duke, UNC, Wake Forest, all right? So people who live in rural communities typically don't have access to these types of therapies. So that's why it's important for you to be an advocate of your disease and ask your doctor, what are all the therapies that are, approved and authorized by the FDA for my disease? Not the therapies that are offered at this facility, but all of the therapies that are for any disease. Very important to ask your provider, please let me know all of the therapies that are for me that have been approved for this diagnosis. Don't sell them for the therapies that they are able to offer you. You want to know all of the therapies that are available and let you make a decision if you want to get access to those therapies or not. But get all of the information. And brings me to my next.
You start getting mammograms. And my thought process and my question has always been,
having these conversations with your family and your children, because aside from knowing their family history, they really need to know how to advocate for themselves. So, I've had this trajectory of cancer through my family, my mother, my husband, it goes through like most of us have been touched. But for myself, at the age of 43, I'm 61, I had my first colonoscopy, and it was have his colonoscopy. And he says, let me show you what I removed. He removed a polyp from me that was so large. He said, if you had waited until you were 50, you would have had full-blown colon cancer.
Wow.
So,
Your family history, as Belinda mentioned, is very important. Gastrointestinal issues run on my father's side of the family. His father was 89, but he died of colon cancer. I had 2 aunts with colitis. I have a form of colitis. So it runs in the family. So I started getting colonoscopies at 49 because I had symptoms. And my doctor sent me to get a colon. So I do every 5 years. Every year I have a polyp. So I go every 5 years, but no cancer.
so in relation to the blood cancer, so my husband had MDS, myelodysplastic syndrome, and he ended up dying from AML. Right. But it was detected with a gout clinical trial where the white count was low. So my daughter's 25. Is there something that I can do, or is there something we could have done with him? Because the only history that he really had was the gout. He had hemochromatosis, but he didn't have anything else.
Right.
And when the white count came back wonky, they were like, it's nothing to worry about, when I had him going. Right. So should there have been some other preventative blood work prior to the diagnosis of this that we should have done? And is there something I should be doing for my daughter?
Okay. Well, how old was he when you entered the gout trial?
50, and he died a year later.
Okay. Now, prior to the gout trial, did he have a primary care provider?
Mm-hmm.
Okay. So he was getting his labs checked?
Yes.
Okay.
Regularly.
Regularly? Yeah.
Yeah.
So.
There was no indication of.
Yeah. And see, that's a rare cancer. And so it's very challenging we don't screen for rare cancers. The reason why we screen is basically to detect common cancers, because screening a common cancer is very important. If you screen for a rare cancer, 100 people will screen for it, you may only get 1 diagnosis. That's a waste of money. And everything is about money. Yeah. And so you only screen for something that you're going to get a high yield. For breast
Markers for my thyroid were really high, and they were so high that they thought it could be cancer. So my doctor said, we need you to have an ultrasound, we can look a little closer. And I wasn't receiving it, but they were asking how I was feeling, my medicine wasn't working. And one of the things she asked was, in your family who's had thyroid cancer, because they'll ask about specific cancers.
Because we don't have the money to pay off, to pay to get the treatments and to get, the medications and all that kind of stuff we need. We rely on our insurance plan, so it's important that, to know that insurance is an issue that prevents.
To breast cancer, about 7 years ago. And one of the questions is I've always had, at 27, even take it earlier than that, at 25, that's
Ask some people, what did they learn about the people at their table?
Shake them up.
Cancer. But I'm treating you something that's imminent, life-threatening, that, you know, that you're dealing with right now. And if I don't treat it, and this is the best medicine to treat it with, if I decide not to give it to you, your chances of dying, if it goes up drastically, then I have to take that risk of you getting this low-grade cancer. Yeah, so it's all about, it's a risk-benefit ratio, and if the risk is higher than the benefit, then you shouldn't get prescribed that medication. But if the benefit, meaning that disease that they're treating, is going and sign themselves up, volunteer their services for these drug trials, they're completely healthy. I can't myself increase cancer. So if you see a change in a weight, think about melanoma.
Because I kept saying, well, why would that have to do with blood cancer?
Yeah.
I'm thinking, I'm reasoning now.
Yeah, no, that's a great question. Yeah.
Thank you.
It's how do you cope with that stress? What do you do when you're stressed? How I grew up around addicts, you know, people when they get stressed, drink, smoke, you know, people guilt, you know, have, well, I forget the phrase that they use, but basically they just eat themselves until they go to sleep.